Shar, I didn't notice how many people. Great, perfect. Okay, so most of you know our main speakers today. Hold on, I got to get rid of that message there. Okay, most of you know our main speakers today, either from your trips to our lamb clinic at Mayo or from the huge amount of time that they've dedicated to our Region 12 meetings in the past. But for those of you that are new this year to our regional meeting, I want to give you a little background on our two doctors. First of all, Dr. Misbah Bakr was born in Saudi Arabia, but she was raised, educated, and went to medical school in Pakistan. She came to the US in 2012 and did a residency in internal medicine in Philadelphia. And then she moved to Denver, Colorado, where she was a hospitalist and also did bench research at National Jewish Hospital. In 2009, she started a fellowship in pulmonary and critical care at Emory University in Atlanta. And she finally found her way to the Midwest in 2012 when she did a one-year fellowship in interstitial lung diseases and vasculitis at Mayo Clinic. In 2013, she joined the faculty at Mayo, and she's currently an assistant professor and director of the Lamb Clinic and the new Interstitial Lung Disease and Pulmonary Vasculitis Fellowship Director. Dr. Mua received his medical degree from the University of Minnesota and did his residency in internal medicine at the University of Wisconsin. He then completed a fellowship in pulmonary and critical care medicine at Mayo and joined the staff in 2012. He is the current director of the Interstitial Lung Disease Clinic and is an assistant professor in the Division of Pulmonary and Critical Care. Congratulations to both of you on your new accomplishments in the past year. And thank you again. I think I speak for all the patients when I say thank you for all the time you put in every year preparing for this meeting and taking time away from your weekend to join us.
You're welcome. I think it'd be reasonable for Dr. Dilling to introduce himself too as a transplant expert. So I'd appreciate hearing from him too. Thank you.
I was going to ask if Dr. Dilling, I don't have a bio for you, but if you want to do a quick summary of your background.
Sure. Yeah, I'm trying to lie low here. You see?
I know.
I'm just kidding. Happy to introduce myself. I'm Dan Dilling. I work at Loyola University, Chicago, where I did all my training and medical schooling. I oversee our interstitial lung disease clinic as well as our lamb clinic, and I'm the medical director of our lung transplant clinic program. So I help shepherd patients toward a transplant and afterwards for all sorts of diseases, not just lamb, of course. And with that background, I also help oversee the Lamb Foundation's program for helping patients who have or need a lung transplant.
And are there two additional Lamb Clinic directors at Loyola in addition?
Well, we have two assistant, you might say, or associate Lamb Clinic directors, Jim Gagermeyer, and I think it's just him actually. Although there are a couple other folks that help out in the program as well.
Okay. If we do this again next year, we'll try to include all of you. This is kind of a informal special guest invitation this year.
Oh, no sweat. We're happy to be here. Thank you.
Yeah, we're happy to have you. Thank you. All right. Moving on to our pre-submitted questions, I did divide them into categories. If you have questions related to the categories, jump on in and ask them. Like I said, we have a random topics section at the end. So if you don't hear a category that your question fits into, throw it in at the end. We'll be happy to cover it. All right. Okay, so the first category is lamb studies. Are there any significant updates on the active lamb studies in the past year? Dr. Bakr, did you want to take that one?
Yeah, so because of the COVID, there has been a lot of, I would say, delay in advancing the research and the studies. But the major studies which you can see on the Lamb Foundation website are the mild
trial, which is for the early LAM. You must have heard of it a lot, to start sirolimus early. And study of disease process of LAM, National Disease Research Interchange, which is to look at the various organs, for example, lungs, kidney, uterus, blood, chyle, etc. Anytime you have surgery, you can donate your tissue for them to look at. Then the MIDAS is just registry study to look at the long-term outcome of patients with LAM, those who are on sirolimus and those who are not on sirolimus, including patients with tuberous sclerosis. Then discovery of sirolimus sensitive biomarkers in blood, which is to look at whether we can look at some biomarkers for sirolimus, which can help to monitor the disease while you are on sirolimus and to see if the dose is effective. And then the bronchodilator effect, whether nebulized versus inhaled albuterol in LAM is helpful. So these are the ongoing trials, and these are the same one which are there on the site for last 2 to 3 years. We haven't seen major results yet. They're still recruiting. So if you look at these studies, there is still no result, but there are a lot of studies which have looked up into other things, and they are smaller studies. Some are retrospective studies, some are lab studies, for example, looking for biomarkers or imaging modalities such as MRI, PET scan, DOTA scan to look at the activity of LAM patients. There is a lot of work on genetics going on. Every time, I mean, there is some new genetic mutations I have been reading about. They're looking into pathways other than mTOR and correlation with presentation and genetics. There are some studies about that. So I think we will hear more about that in our LAM meeting in September. But I would also like the input from Shar, if she can tell us that if there is any active updates, but I did not see anything regarding these major studies.
Yes, hi, thank you, Dr. Bakir. I don't have anything to add to that really, other than that in a more broad sense that the NIH is now seeing patients again for the people who have been participating, in the longitudinal study. That it does, the shape of that is a little bit different that visit due to lodging and that kind of thing. But I think you've covered that very well, and I'm sure we will have updates at Lamposium and then to follow in our LILR series, Lamposium in Your Living Room series for those unable to attend the in-person conference.
All right, and then just anything additional to say about new studies that are coming up? That was the next question. If there's anything new on the horizon that we haven't talked about.
I think I am not aware. Maybe we will hear more about in the LAM meeting. Teng or Dr. Dilling, do you know of anything?
No, only to say a lot of people ask about the status of the Resveratrol trial. That was a study looking at that extract a couple of years ago at University of Cincinnati through Dr. Nishant Gupta. And so a few of my patients actually have traveled there and been involved in that study, which is now completed, finished enrollment completed. All study activities are done and the data are still yet to be analyzed. But so lots of people wonder when that will be announced or publicized, but so far no information. But it's also not something people can get involved in anymore because it's completed.
Sure.
The only thing I might add is just a couple of studies that were published looking at statins in combination with the mTOR inhibitors or angiotensin inhibitors, ACE inhibitors, and there were more exploratory studies looking at sort of that combination and seeing if that had impact. And it's sort of a mixed assessment. These are early kind of studies too, and they were published in the literature, but probably not necessarily something that you could contact and get involved with. I think in Europe there is some interest in OFEV using an antifibrotic as well, and one of the sites out there, but not in the US. Yeah.
Okay. And the next question is, does Mayo, and I'm going to include Loyola as well, since we have Dr. Dilling, ever do LAM studies, or do they ever collect data samples for LAM research that's going on at other facilities?
So we are only involved in MIDAS trial, and in that we do collect samples in the first visit. Otherwise, we don't collect samples for other studies. Like when Mayo is not the site, we don't collect samples for other studies. You have to go to the site which are involved in the study, but we are only doing MIDAS trial. I know that Loyola is involved in MILD too, and they have and in the MIDAS they have enrolled the highest patients.
Okay. All right.
Yeah. I would just add to that. Yeah, that if a patient is going to be undergoing a lung transplant, there's actually a program or a process that's in place through the NDRI, which is sort of a pseudo-governmental agency for collecting samples and biorepository, it's called. So there's a way to sign up to donate your tissue to the NDRI for research in LAM that could be from anywhere in the world, literally. Those samples can be retrieved and used for study without your identification involved in it. And so that could be at Mayo Clinic, that could be at Loyola. There was recently one somewhere in Florida where the samples can be retrieved. There's some paperwork that has to be done, some preparations that have to be made while you're on the wait list, et cetera, but that is possible.
You have to contact this NDRI yourself, like beforehand, before undergoing surgery?
Yeah, the basic answer is yes, but you're not out there on your own. Actually, Charlene and the LAM Foundation are very helpful in making it all happen and helping you get the paperwork and get it to the right place, and coordinating with your lung transplant program as well as the NDRI. And then, believe it or not, they send people on airplanes to get samples at your transplant hospital. So it's really involved.
Wow.
Very good.
Yeah, I believe we have at least a couple of people, based on the transplant questions we have, I believe we have a couple of people here that are either listed or considering being evaluated. So I don't know how many of you know that. Charlene, you still run Circle of Hope, right?
I do, yes.
Be the LAM
With
Foundation.
Dr. Dilling, and Dr. Dilling, as he mentioned, is our scientific director, medical director for the program. So
Yeah, so they can reach out to you if they have questions, right?
absolutely. I'll put my email in the chat box.
Perfect, thank you.
Yeah.
All right, one of the patients asked about, oh, I'm sorry, go ahead.
I was going to say, can you just clarify for new people what Circle of Hope is?
Sure, Sharon, I'll give a really brief, and then we can circle back to that in your random, because I know you have.
Or
So,
later, it doesn't.
yeah, how about Bev, remind me, and we'll circle back to that. Thank you, it's a good question, yeah.
Yeah, it is a good question. Thanks for asking that. Yeah, let's take a note to circle back to that. Thank you. All right, so one of our patients asked about an article that several of you may have seen on the LAMI site that referenced an increase in Alzheimer's associated plaques in mice that were given rapamycin. And she was wondering whether, based on this, the doctors had any thoughts or concerns about LAM patients taking the drug. Dr. Bakur, I'm going to go to you.
So I did talk to Dr. Gupta about this question too, because I wanted to make it clear if he has heard anything about the effect of rapamycin causing Alzheimer's or dementia. And he had not heard about this, but he looked at the article, and his response was that this was preclinical data with not unclear results, especially in humans. He said there is more preclinical data in support of use of Serolimus in preventing dementia rather than causing it. So therefore, based on these results, there is no reason to pause using it or to have concerns about dementia related to Serolimus. So I would ask Teng or Dr. Dilling's input too.
No, you said it perfectly, Miss. But I'm not an expert on that topic. But when you just PubMed and look at the 300 to 600 plus articles, the majority of the evidence points towards it being a positive. At least all of it is all preclinical, meaning non-human studies, and people are. There's one very nice kind of summary editorial that says, "Why are we not doing studies looking at mTOR for preventing or helping with Alzheimer's rather than what this particular article had said?" Having said that, that's how science works. You'll have multiple results that go against one another, but the overwhelming weight probably would not suggest a harmful effect, and in fact, perhaps in the future, a more beneficial effect.
Yeah, I often tell people when they bring a preclinical article like that with a concern to say that it's always important that more information be collected, more other preclinical information and studies be looked at, because there are differences in outcomes in many articles, and it's really the preponderance of the evidence that will point us towards one or the other direction as the right conclusion, and we shouldn't hinge everything on one article in this way. But I guess it tells us that we shouldn't be giving Serolimus to mice unless there's a really good reason to do so.
Good point. All right. I haven't seen any other questions come in on LAM studies, so I'm going to move forward to our next category, which is transplants. So the first question is, if one has a lung transplant, does this cure them of LAM, or can the LAM cells return to the new lungs?
I think these transplant questions should start with Dr. Dilling.
Okay, that's fine. There are only a couple of diseases that we do transplants for that have been shown to once in a while return to the transplanted lung, and LAM is one of them. But it's very unusual for it to happen, and if it does happen, it's almost always a very, very mild situation. And furthermore, treatment with Serolimus would make good sense in that situation to slow down the progression or worsening of it. I have only once heard of a case where the return of LAM was so significant as to cause major problems for the person. So it's not a reason to second guess the idea of doing a lung transplant whatsoever, but it is a reality, and it's something that probably needs to be thought about going forward for the remainder of your life after a lung transplant, if you have it for LAM.
Okay. Did anyone else want to comment on that?
The largest study for looking at transplant patient in LAM, which is 134 patients, only 1% had recurrence of LAM. So it's it can happen, but the chances that it will happen is very, very low. And as Dr. Dilling mentioned, that's not the reason for not to have lung transplant if you are eligible for it.
Okay.
The only thing I would add was, I think in a similar kind of setting, I think they did a UNOS kind of evaluation of LAM patients, and they had a very good survival, median survival of 12 years or so, which is, as Dr. Dilling and Dr. Pakir might know, is often better than the other indications for transplant as well. And that might be hinting at the fact that this recurrence is relatively rare. And if it does occur, it's not a very severe morbid situation that requires additional retransplantation or anything else that's beyond that.
An excellent and really important point. Yeah, the likelihood of long-term survival after lung transplant for LAM is way, way, way better than for any other disease that leads to a transplant. It's the best likelihood of long-term survival of all patients who have a lung transplant. So it's not a reason to be afraid of transplant.
Great. Okay, the next question is, my DLCO is dropping much faster than any of my other PFT test numbers. Is DLCO taken into consideration when determining if you need a lung transplant? And maybe, Dr. Dilling, I'm going to give that to you. If you could explain, we do have some new people joining today. If you could explain what DLCO is.
Can you just read the question one more time, please?
You bet. My DLCO is dropping much faster than any of my other PFT test numbers. is DLCO taken into consideration when determining if you need a lung transplant?
Okay, so the diffusion capacity, or DLCO, is one of the numbers that you get on a complete pulmonary function test, it's not on the simple spirometry or the spirometry with bronchodilator that you might get more regularly with your doctor. But anyway, it's a substitute for helping us understand how well oxygen and carbon dioxide exchange themselves in your lungs between your blood vessels and your air sacs. So it kind of gives us a measure of disease in that respect. So we do worry about it when it's going down, but we don't worry about any one number in isolation. The truth is that the whole patient has to be considered in any care plan, and specifically the care plan of whether to do a transplant. So I wouldn't look at it by itself in thinking about whether someone needs a transplant anytime soon, but if it is also true that the person is needing more oxygen than before, or needing oxygen very consistently, or maybe their FEV1 is going down as well, maybe their quality of life or activity endurance is going down, maybe they've had an exacerbation that's put them in the hospital, or maybe they've had development of pulmonary hypertension. Any of those things, and especially a few of those things together, are what push us towards saying that someone's at the point of needing a transplant. But we really, my overarching philosophy on timing for transplant is you don't want to do it too early, because a transplant is brings with it a whole set of problems and complications, and you really don't want to trade for that until you're at a point where you're worse off. So we really wait for someone to be on a fair amount of oxygen and limited in their endurance, and feeling really sick without any other alternative pathway for getting better before we think a transplant is the right time. So DLCO is one piece of the puzzle, but I'd actually say it's a smaller piece than those other things.
Anyone else have input on that?
So I think I totally agree with, I cannot disagree with Dr. Dilling in that. It's not my area of specialty, but what I read about, like when we refer patient to LAM, there are certain, for all the diseases, there are certain criteria, like COPD would have its own criteria, pulmonary fibrosis would have its own criteria. So that is like to help the physicians when to send patients for lung transplant evaluation. So the criteria that, I mean, obviously it may not be that tight, but that helps at like it's like a guidepost for other physicians or pulmonologists to look at. And in that, DLCO is not one of them, but there could be other indirect measures that will lead towards low DLCO, that will indicate low DLCO. So for example, one of them is that as Dr. Dilling mentioned, that how short of breath you are. If you there is a classification system called New York Heart Association, where they look at how short of breath. If you're class 3 and 4, which your physicians will know about it. So it's basically severity of shortness of breath. If somebody is rapidly progressing in respiratory impairment, if your FEV1, which the spirometer measures, is less than 30% predicted, and again, these are not like hard and fast rule. They just help the pulmonologist to send patients for lung transplant evaluation. And hypoxia, like if your oxygen is going down. In somewhere I read if multiple and recurrent pneumothoraces are going on, which I'm not 100% sure, but I can ask Dr. Dilling's input whether this is correct or not, but whether this will be an indication or not.
Yeah, so you're referring to the guidelines of the International Society of Heart and Lung Transplant. Those are fairly new guidelines that just came out at the end of last year. And for the first time ever, there is a specific section speaking about LAM and selection of candidates for lung transplant with LAM, which is only 1% of all lung transplants worldwide. So it's actually quite wonderful that there's a specific call out for the disease. And so I think Dr. Bakir's point is really important, that the guidelines talk about when to refer to a lung transplant center, and they also talk about when a lung transplant center should think about putting someone on the list. And those actually are two different things. We actually want people to meet the lung transplant team before it's too late, and probably when it's a little too early, so that there's maybe time to get to know the team and learn some things and work on some health issues before you're finally needing a lung transplant. You go on the list. So 30% is maybe a guidepost for when to start seeing a lung transplant center, but it's definitely not always the time to go on the list. And I've cared for people for years who are well below 30% and don't need a lung transplant and haven't had one yet. And so it's really, like I said, it's looking at the whole person as you make that decision. And then with regard to recurrent pneumothoraces, that would have to be a very unique situation where someone has gone through all the usual ways of trying to deal with pneumothorax, like tube and pleurodesis and maybe a second pleurodesis, and they'd have to be significant pneumothoraces that, not just a tiny one that keeps coming and going or something, but it'd have to be a really life-threatening, problematic recurrent pneumothorax. And that's, I don't think I've ever seen that situation in a LAM patient. So I think it's probably nothing to usually be thinking through, except in a rare situation.
Yeah, thank you. Because I was also thinking that this does not make too much sense to me, because there are so many patients who have multiple pneumothoraces. So that's why I wanted the clarification. Thank you for that.
To add on that, while we have you, Dan, could you comment on the pneumothorax risk in a transplant? I've had several patients, and I'm not an expert on that from a surgical perspective, and I think that fear of getting a pleurodesis or fixing these recurrent clinical pneumothoraces is maybe not as high as what we think, and they can get that done for quality of life and perhaps not knock themselves out of a transplant in the future. And what your experience has been with that.
Yeah, so the point here that is being discussed is that there are some lung transplant centers, and there used to be more, but there still are some who deem a person ineligible for a transplant if they've ever had a TELC pleurodesis, a TELC specifically pleurodesis. And there might even be some that are nervous about other kinds of pleurodesis in your history too. And so that's the truth, that there are some programs that are unwilling to transplant you with that history. That said, the guidelines for treatment of LAM, totally separate from needing a lung transplant. The guidelines for the treatment of LAM will say that anyone who has their first pneumothorax and who has LAM should get a pleurodesis. But it also goes on to say that ideally that pleurodesis should be a mechanical pleurodesis or maybe sometimes a chemical pleurodesis, and probably try to avoid the TELC pleurodesis, again, with that same thought in mind that it might make transplant more difficult or ineligible. And so the truth is that if you have had a TELC pleurodesis, that there are transplant programs that will go ahead with a transplant. We all must realize, and it's inarguable, that a transplant is going to be more difficult for the surgeon to do, more difficult for the patient to get through, will probably require more blood products and have more issues with bleeding in the period around the transplant. And that's because the TELC pleurodesis really adheres the lung to the inside of the chest, and it makes it more difficult to extract it for the transplant. That's the bottom line. But at the end of the day, if you ever have had an evaluation for a transplant and we're told you're ineligible because of a TELC pleurodesis, you should go to another lung transplant program, because that is not going to always be the answer. And the one last thing to say is those guidelines from the International Society of Heart and Transplant also stipulate that TELC pleurodesis should not be an absolute contraindication to a transplant. But the truth is, every program makes their own decisions about how they're going to proceed with the selection of patients. And so it's not a guideline that must be followed. It's a guideline that is suggestions.
And just for the new people on the call, Dr. Dillon, could you just give them an overview of what a pleurodesis is?
Okay, a pleurodesis. Actually, I think this would be a good answer. I'm speaking too much. Why don't we have the other doctors talk about a pleurodesis? I think that'd be a good question for someone else.
Teng, you want to do that?
You can go ahead, Misbah. Yeah.
So basically, pleurodesis is a process where if somebody has pneumothorax, there is air between this outer surface of your lung and the chest wall. So what happens is when air comes in, the lung tends to collapse or shrink. So in order to open it, you have to bring the outer surface of the lung back against the chest wall. So there are different methods of doing that. Then, I mean, the whole process is called pleurodesis, but there are different methods of how you can do it. So talc is one of the material, the powder talc that we use in our daily living, maybe. So that has, I don't know what the exact word, but it has this property of absorbing to the surfaces. So you can instill this talc as either a slurry or as a like you instill as a powder, and you can. It looks like a sandstorm when you actually look at it. So that acts as an adsorbent material to bring the surfaces against the chest wall and to bring the lung again inflated. The other one is mechanical pleurodesis, in which the two surfaces are kind of rub so that they are rough and they adhere to one another. The studies have shown that mechanical pleurodesis is the best way of doing pleurodesis. And sometimes, is there any third one? As a doxycycline is also used or was used. I mean, they used to do doxycycline as a drug, but I don't know whether that is very commonly done anymore. Anything to add?
Just specify that doxycycline is putting the doxycycline into the space around the lung, not through your blood or something. So it's putting through a tube or maybe even through a surgery, spilling some doxycycline around the lung in the chest cavity so that it irritates the linings of the lung and the chest wall, and they stick to one another so that there won't be a collapse anymore. And it's still done sometimes, but it's usually not the first choice. It's usually a salvage or a second try kind of thing.
Mm-hmm. Yeah, and at Mayo, I have talked to our transplant doctors. They don't say no to somebody who has talc pleurodesis done. It's just that we have to understand that the transplant can take longer and there would be more bleeding, as Dr. Dilling said. So, but as Dr. Dilling said, if you have had talc pleurodesis in the past and you need a lung transplant, most centers won't say no based on that, but obviously if some centers say no, you try another center at that time.
To go back to an earlier point, it's really important that everyone understand that if you have a pneumothorax, you should get a pleurodesis. You shouldn't avoid all pleurodesis because you're afraid of this discussion that we're having. If you've had a pneumothorax, it's a definite recommendation to have a pleurodesis. Ideally, the mechanical pleurodesis that we spoke about.
I have come across some patients who had very small pneumothorax. So other than LAM patients who have small pneumothorax, like less than 5 centimeter, you let them go and resorb on its own. And that is, I have seen one of my LAM patients in the cities came and had multiple pneumothoraces, but they were small. And they went to ER and they said, no, we're not going to do anything. This will go away on its own. That is not true. And for LAM patients, that's not true. No matter if it is small or large, it has to be taken care by pleurodesis because the chances of recurrent pneumothorax is 70%. So this will happen if you will not take care of it right away.
We did have a question in the chat about whether or not staples are considered mechanical. I've never heard of staples being used.
I'm not aware of it. I don't know whether Dr. Dilling or Teng, I don't know.
I guess Ms. Roney can clarify with the group too.
I think probably referring to someone who has had a bleb stapled. So they probably had a pneumothorax, and then the surgeon went in with a VATS kind of surgery with the video and saw a bleb, and they just removed that bleb and they put a staple line across it and don't do a pleurodesis. It would not be considered a pleurodesis.
It's not pleurodesis.
And in fact, I would say, it may be too late, but I would say that that person probably ought to have gotten not only the bleb removal and staple, but a pleurodesis at the same time if it had been a pneumothorax that led them to that spot.
Okay. Thank you for explaining that. Our next question is, what information is available about dual listing for a lung transplant? Is it possible to list at Loyola or Mayo in Rochester in the summer and at Mayo in Jacksonville, Florida in the winter? Someone likes to winter in Florida. Dr. Bakur, did you want to take that one?
I think I will ask Dr. Dilling input on that.
Okay.
All right, so I've never heard of that idea because while you can list in two places,
yeah,
it's obvious that you need to be relatively close and able to get there in at least several hours, so that sometimes the transplant is happening quite expeditiously and there's no time to fly in from another place or drive very far to get to it. So with that said, if you're going to list in two places, it's usually going to be two places that are relatively close driving distance, like Mayo Rochester and Chicago, or like St. Louis and Chicago, or Cleveland and Chicago, or something like that. And even those might be a stretch sometimes. But this idea of wintering somewhere and back and forth, I've never considered the idea before, although one of my patients is recently going through that consideration, and it's unusual, but probably workable. Just, it's up to each particular transplant program as to whether they're willing to go along with such a plan, and that's up to them.
When I discussed this question with our transplant physician here in Rochester, they said that there are two problems. One is your insurance, whether the insurance will approve it to be listed in two places, obviously. And then you have to sort out the transportation. You have to be in a certain radius distance whenever you are, I think it's 400. Dan, am I correct in that?
I usually say it in hours. If you got to be able to get in within 4 to 6 hours, we'll say. Some other places might say fewer hours, but the concept here, if you're in very far away, like Florida and Chicago, which was the example given, is that when you went to one, you'd be put on hold in the other. And when you went to the other, you'd be put on hold in the other one. So I suppose it's doable, but insurance has to play ball, and each program has to be willing to go along with the plan, but it's doable. You have to have your support team ready to care for you in whatever place it's going to be afterwards. And you have to be willing to live permanently in the place near your lung transplant program afterwards, because you can't shift your care back and forth afterwards, especially in the early period afterwards.
And the doctor here, the lung transplant doctor, also told me about this seasonal thing, that he was of the opinion that would be too much of the effort and money to be worth it, and you have to have too many doctor visits, because when you are listed in two places, they want to see you too often. So, and he was also thinking that by the time you will be done with the paperwork at one center, it might be time to go back to the other area. So he was not of the opinion that it will be worth it. It can be done, but it's whether it is worth that effort or not, that is the question. And he also said that it is better to, as Dr. Dilling said, that it is better to be enrolled in an UNOS area which are closer to one another, so that you are available at the two places at a reasonable time and distance. So Tang, I don't know whether you want to add anything.
No, I guess this is just for everybody's learning as well. But are there advantages to having? I didn't know if you could enroll in two UNOS sites at the same time, meaning that would just increase your risk of. Increase your chances of getting transplanted. And I understand that as well. That the one evaluation in one site cannot be transferable to another site without their having their own reevaluation, and sometimes that second evaluation is out of pocket on your own. At least that's my understanding to a certain degree. But some of the questions that have been brought up by patients are what I bring here.
Yeah, it's doable from even insurance will allow it, and the rationale is usually not for travel or wintering in another state, but it's usually because you're maybe a person of short stature or a person who has some antibodies that restrict how many donors are available to you. And by going in two different places, say Cleveland and Chicago, you might have geography plays a part in the allocation of donors. So you kind of expand your geography of where your donors can be. So that's usually the rationale for it. And it can work, and you just have to be ready to be living and cared for in that city afterwards, and there might be some insurance restrictions, although often there's not.
That makes sense. Okay, so what determines if you qualify for a single lung transplant or a double lung transplant?
That's a determination made after you go through all the testing at the site, and the team, including the surgical team, will make a decision that might bring in such factors as how old you are, whether you have pulmonary hypertension, whether you've had a pleurodesis on one side or the other or both sides may be a part of the consideration, whether you have antibodies that restrict how many donors you have, or if you're of short stature, restricting what donors you can have. All of these things may influence a decision, or maybe you have a nodule on one side that must be extracted with the transplant, or maybe you have had lots of problems with pneumothorax on one side, and so definitely that side needs to be transplanted. I guess I'm explaining that there are a number of factors that might go into the rationalization of whether or not someone needs one or two lungs. But people can live with one lung and do very well for a very long time. And so that's often the best choice, but it's not always the best choice. Sometimes the two lungs is the best choice. And so it's individualized by your team after you go through all the evaluations. And I always tell people that you only need one lung, and the proof is that Pope Francis, Catholic Pope in the Vatican, he has only had one lung since he was in his 20s. He had it removed for some kind of infection or something. So that tells you he's an old man. So you can live with one lung for a very long time.
Absolutely. Any other comments on this?
Well, another thing is that I think if you're too frail and you cannot tolerate cardiopulmonary bypass, like during this procedure, that could be one factor for doing only single rather than double. The international study for 134 lung transplant patient, majority of them had bilateral lung transplant. I think that is preferred over single, but it obviously, as Dr. Dilling mentioned, due to many other factors, you can end up having single lung transplant. Also depends on the donor pool as well.
Okay. Dr. Moa, did you want to add anything?
No, thank you. Yeah.
Okay. All right. So that is the end of our transplant section. I did want to ask if we could just clarify, because we spent a lot of time talking about transplants, and we do have, like I said a couple times here, a lot of new people on. It's kind of a scary topic to hear about when you're first diagnosed. Do we have any statistics around how many LAM patients actually end up having to have a lung transplant? Or could we maybe look into it?
It's
Dr.
very
Dilling,
small.
yeah.
In the US,
Yeah.
it's on the order of something like 5 to 8 per year.
5 to 8 per
in
year.
the whole US. And the numbers that were put on the list and transplanted did go down significantly after Serolimus became part of normal therapy for everybody.
Right.
Yeah,
Which tells you something about how good that therapy is. Imperfect, but how good it is.
Yeah, this is what exactly our lung transplant doctor also said, that we hardly do any transplant. For many years, we have not done any for LAM patients. Ever since Serolimus has came, it has dramatically gone down.
That's good to hear. Great. And then we did have one final question here about how pleurodesis would affect the decision to do a single lung transplant versus a bilateral. And I think we kind of touched on that.
It might be the reason that a single is done instead, just to avoid the operative complications that can come from trying to take out the pleurodesis side. So although some programs would still forge ahead and say we're going to do both anyway because we think both is the best way to go in this individual.
Mm-hmm.
And one thing, if God forbid you need lung transplant and you are listed, one thing that patients can do is to talk to the others who have got lung transplant, like Shar would be one of them. And as mentioned before, the Circle of Hope program is excellent from LAM Foundation to contact them to get some support from them.
Yeah. You do a great job. Okay, moving on to medical testing and vaccinations. The first question is, since my family doesn't have a history of colon cancer, my general practitioner is recommending that I do a Cologuard test rather than a colonoscopy to avoid anesthesia. However, I'm on Rapamycin. Does that put me at a higher risk for colon cancer? And do you recommend one option over the other for LAM patients on Rapamycin?
What I have read about Rapamycin, it does not increase your risk of having cancer. Actually, it might have some anti-malignancy effect. If you are at low risk for having colon cancer, such as no family history or no history of polyp, etc., the indications to undergo Cologuard or not to have Cologuard is the same as for anybody who is not on Rapamycin. So you can definitely have Cologuard as the screening tool. The only malignancy or cancer-like situation which is associated with Serolimus is in after transplant, which is post-transplant lymphoproliferative disorder. But that is in transplant patient, which the Serolimus might increase the risk, but otherwise it doesn't increase the risk of colon cancer. Tang.
Yeah, I concur. That's exactly what my understanding is as well. So the procedure to decide would be based on a typical population risk, not anything unique to LAM in this setting.
Dr. Dillon, did you have anything to add?
Nope, nothing additional.
Okay. Do you recommend an annual skin cancer check for all patients on Rapamycin, no matter what age?
As I said before, I don't think so there is any increased risk of skin cancer being on Serolimus. So what I know that we don't recommend, and actually there was a study on kidney transplant patients who had at least one squamous cell cancer in the past, and they were compared, like patients on Serolimus were compared to other immunomodulatory agents, which are broadly categorized as calcineurin inhibitors, which are used in transplant patients as immunosuppressants. And the risk in Serolimus of having a recurrent skin cancer was less compared to the calcineurin inhibitor, and it was significantly less. And there was also a meta-analysis which showed that Serolimus actually lowered the risk of non-melanoma skin cancer. So I am not aware that you should undergo like annual skin cancer screening while you're on Serolimus.
Okay. Any other input on that?
Yeah, very similar findings when I kind of read through the literature too. It wasn't in my knowledge that rapamycin increases risk of skin cancer alone. There is increased risk of skin cancer post-transplant in a bunch of series and different organs that were transplanted, but not necessarily due to the specific immunosuppression from Serolimus. In fact, they looked at it and they found just demographic risk factors, not so much the fact that you had a Serolimus or any kind of immunosuppression. In fact, no form of particular immunosuppression was seen in certain series of solid organs that were transplanted. So I don't think we can take that population and transfer it over to lamb and say that your risk of skin cancer is also high for that reason, because the only drug you will be using will be Serolimus. And as Dr. Bakir mentioned, that didn't seem to increase that risk even in post-transplant.
Okay.
I apologize. I stepped away for a second, but I know the question, and maybe this has already been said, but in the transplant populations, Serolimus has been shown to reduce the likelihood of skin cancers. And so we commonly add it to the care plan of all patients, not lamb patients, all patients after a transplant if they're starting to have recurrent skin cancer. So that can give us all solace in a lamb population before a transplant that it probably isn't a worrisome risk for skin cancer. It might even be helpful.
Interesting. We did have a question come in through the chat about anesthesia. Back to the colonoscopy. Is there a concern with people being put under? That's a bad way to say it.
My answer would be theoretically probably no more than the general population, but it's based on your lung severity at that time. And so if you are someone who's more advanced on oxygen and you're a little more ill, there'd probably be closer monitoring. The anesthesia for colonoscopy is what we call monitored anesthesia care. It's more sedatives, it's pain control and things like that. I was told if you are tapped on the shoulder, you should be able to wake up to what's going on. So you'll be very comfortable, but you should not be, it's not general anesthesia. And if you had an emergent surgery where you needed general anesthesia, I don't think having LAM in and of itself, at least from a biochemical standpoint, where you don't process the anesthesia drugs as well, or it's probably more respiratory risk, and that would probably fit with any other chronic lung disease.
I think FEV1 probably, so for colonoscopy, it's moderate sedation. It's not general anesthesia, so I don't think so that is a real problem. But if you're talking about general anesthesia, so any obstructive lung disease, if you have low FEV1, I mean, if you're actively wheezing or have an infection, or that could be a problem that you have to like do inhalers and have optimal respiratory status before undergoing general anesthesia. So that would be for any obstructive lung disease. But otherwise, I do not think that there would be any additional risk for undergoing anesthesia. But maybe Dr. Dilling would also, can I add more?
I agree with all those things. I'll add 2 points. One is if you're a patient who has severe pulmonary hypertension as part of your LAM, and that meaning you're on special drugs to control pulmonary hypertension, that particular group of patients has a higher risk with anesthesia, as do anyone with pulmonary hypertension. And then the second point is, I care for lots of patients with low FEV1s and on oxygen and et cetera that are, of course, I'm caring for them because they're headed toward a transplant, and all of them get colonoscopies and all these types of procedures within heart catheterizations with sedation. And it's obviously people need to pay attention and be careful and such, but all of those types of procedures, sedation like this is possible and can proceed.
Okay, great, thank you. Do you recommend any vaccinations or annual blood tests for LAM patients that wouldn't be on our general practitioners list for physicals?
So for annual blood test, I think my take on the effects of Serolimus is that I think that because it affects the lipid profile, so annual fasting lipid profile probably would be something that would be, I think would be helpful. Hemoglobin A1C would be another thing. Kidney functions and CBC, kidney functions particularly to look at proteinuria and CBC, and you can either do it quarterly or every 6 months, these lab tests while you are on Serolimus. As far as vaccines are concerned, I think there would be your usual vaccines which are recommended for other people, like for example, pneumonia vaccine, influenza. And then there are certain vaccines which are usually for high-risk patients, but we all get it, like hepatitis A, hepatitis B, or meningococcus, H influenza at risk patients again, and Tdap, and herpes, the zoster virus, which is not live, the RZV, the recombinant zoster virus, that is usually recommended for immunocompromised patients, not the live vaccine, and obviously the COVID-19 vaccine. So I'm not aware of any other special vaccinations.
Anyone else have
Just
input?
just to specify that by the zoster, you mean the Shingrix is the
Shingrix.
brand name.
Shingrix,
Shingrix
yes,
is the
yeah.
one that's safe to do if you're immunosuppressed. So
Yeah.
that's
Not the
main
live,
key
yeah.
name.
Yeah.
Yeah, that's the key, is the name Shingrix. And the
Shingrix.
second thing to say is the pneumonia vaccines. There are two of them, and generally, a Prevnar, that 13, and there's a new Prevnar, are usually not recommended until you're older. But in someone with lung disease, and especially someone on Serolimus, which Lamb would hit both of those boxes, I recommend both the Prevnar 13 and the Pneumovax 23 pneumonia vaccines, despite the young age.
Yeah. Okay, Dr. Moore, anything to add?
No, that was excellent. Thank you. Yeah.
Okay, so I had someone said that they had their COVID booster in February, and I have several large group in-person events coming up in the fall. Will my booster still be effective at that point, or will I need another one?
So usually for immunocompromised patients who are on, I don't know whether this person is on Serolimus or. No, it didn't mention. Okay, so if you are immunocompromised or you are on Serolimus, then the recommendations are three primary like Moderna and Pfizer, and 2 boosters. But if you have received 2 primary, like the one that everybody of us have got, and you have got 2 boosters, I think you should be okay. But the problem is that the new variant of Omicron, that BA2 variant, we have seen among our colleagues and who are vaccinated and boosters, they got that. So it looks like that the new variant is more, it is easily communicated, but it is not that virulent. So there is a possibility that even if you have your booster vaccination and you are vaccinated, you can get it. So if you are meeting in large groups, then the mask and social distancing is still recommended, or frequent hand washing is still recommended. But as I said, that you still can get this Omicron, which is now it is decreasing in number as far as I know. But there's a risk. You can't say that you're boosted and you cannot get it.
Okay. There was a question that came in about stopping Serolimus after we get vaccines. Is that something that's recommended, to stop taking Serolimus?
I don't recommend people stop Serolimus for the sake of getting a vaccine. I suppose there was some thought around this possibility when the vaccines were first coming out, and a lot less was known. One important point to say here is that, and this is very reassuring and comforting to everybody, I hope, there was a study that came out that looked at the experience at a handful of lamb clinics around the world, and around lamb and Serolimus and getting COVID. And this is before any vaccines were out there. And what was seen was that the likelihood of getting COVID at all seemed to be no worse if you had lamb compared to a general population. The likelihood of getting severe COVID seemed to be no worse if you had lamb versus didn't have, the general population. And if you had lamb and you got COVID, your chances
The presence of sirolimus.
chances of
sirolimus
dying
did
were
not-
no worse. And if you were on sirolimus or not on sirolimus, also didn't seem to influence how bad or how likely it was going to be that you got COVID. So I think we all must have a level of concern and carefulness and try to avoid getting COVID and mask and space and all these things. But I don't think LAM patients need to be over and above, over the top, worried in a way that, say, a lung transplant recipient needs to be.
If they're on sirolimus, they can probably get this Evusheld, the prophylactic monoclonal antibodies to prevent a severe COVID. I think they would be eligible because of being on sirolimus.
Okay, yes, we did have a question come in about Evusheld. Like, did you see that? Dr. Bakar, is that the one you're referencing?
I think they're talking about Paxlovid, right?
No, it says I got 3 COVID shots in the primary series and 1 booster. I also got the higher dose Evusheld. Do I still need a second booster? If so, when?
The recommendations are for 2 boosters, whether you get Evusheld or not.
Okay.
It's clearly defined in the CDC guidelines that if you're immunosuppressed, that the first 3 are the primary series. So the 4th one is your first booster and the 5th one is your second booster. So people, if you're on everolimus or sirolimus, then 5 is the number of shots. If you're not on sirolimus, then 4 is the number of shots as of today. And with the only difference being if you had Johnson & Johnson as your first one, then it ends up being 3 is how many you should have as of today.
Okay. Thank you for the clarification.
And my practice around Evusheld is a little different, and meaning because of limited supplies, at least last time I checked, there were still somewhat limited supplies. I was reserving it for people that were at the highest risk. And so that was people with organ transplants or maybe some rheumatology cases that were patients on a lot of immunosuppression there. Sirolimus, in a way that I just described, I think is not one of the highest risk categories, although technically would qualify given that there is technically an immunosuppressed status.
In Minnesota, there was a shortage of Evusheld when it first came. So it was reserved for patients, or it was actually under lottery. So, and it was only for people who were on rituximab. And so not all the patients who were immunocompromised were eligible to be selected for that lottery process. But now I have heard that it's not, in Minnesota, it's not under lottery anymore. So people who are immunocompromised, they have been selected to get it.
Okay. Anything else anyone wants to ask about medical testing or vaccinations? Otherwise,
I think there are questions in the chat.
Yeah, let's see, we have a few. I think we've covered most of them here.
This is the last one. Should we stop sirolimus if we're put on Paxlovid?
Oh, thank you. Yes, I missed that one.
I am not aware. I might not know all of it about Paxlovid. I'm not aware.
What is that? I'm not even sure what that is.
Oh, Paxlovid is an antiviral drug.
Oh,
So if you get,
The answer
Go
is
ahead.
that you should hold to the sirolimus. I mean, you should consult your doctor, and your doctor should probably be consulting with their clinical pharmacist on the team, and that's what I do. But the drug should more than likely be held for the duration of the Paxlovid and even a couple of days afterwards. And it's not like you're going to be off of sirolimus. As a matter of fact, if you were to measure blood levels through those days, you'd end up still having sirolimus in your system for all those days. And that's exactly what the Paxlovid does, is it potentiates, it makes it the levels higher, which is why if you stayed on it and Paxlovid, you'd end up with too high of a level of sirolimus. So consult your doctor if you have to go on Paxlovid and you're on sirolimus.
so basically it should be on hold.
That's going to probably be what you're told. I
Okay.
wouldn't want to supersede what anyone's individual doctor or pharmacist, clinical pharmacist is going to say. And this isn't your pharmacist at the Walgreens. This is your hospital pharmacist.
Yeah,
who
that
helps
people
your
who
doctor decide on doses and stuff.
Okay. Tang, do you?
Sharon,
You want
if
to
I
add?
may- Oh, I'm sorry, Dr. Bakir, go ahead.
No, I was just asking Tang if he
No,
wants
please,
to add.
please go ahead. No, no, this is excellent. I don't have anything to add.
Yes, great discussion, Sharon. I'm just going to interject real quickly here. We do, because of the way that last minute meeting link was sent out last night, we do have a few of you who are logged on under my name, and we have great questions coming into the chat box, and I'd like to be able to follow up with you individually. So if your name is still showing Charlene Dunn, if you go to the upper right corner in your little own icon of your picture, you'll find 3 dots. And if you could change it to your name, that will help us tremendously with follow-up. Thank you.
Thanks for catching that.
Yeah.
And we did have a question about sending out a transcript for this meeting too. We are recording, and once the recording is ready, the LAM Foundation has it ready to go. We'll send out the link to it.
Correct. Yeah.
Okay, so the next topic is COVID, and we've already kind of started going through these questions a little bit. What precautions do you think LAM patients should be taking to protect themselves from COVID now that things are opening back up and people are no longer social distancing or wearing masks? Dr. Mua, do you want to take that one?
No, I think Dr. Dilling's excellent point earlier about the LAM specific studies should be taken to heart, and that your having LAM does not increase your risk of getting it more than someone else. And perhaps the severity of disease when you get COVID is going to be similar to what someone else may be going through, even with COVID, even with being on Serolimus.
Mm-hmm.
And so I don't think I could specifically recommend a isolated practice that you should do because you have LAM. I think it's you would take the same precautions everybody else would, just based on that knowledge or information. If there's no real evidence to say that when you walk into a crowd and you have LAM, you are now 5 times more likely to catch it, get sick from it, or become have a longer time recovering, that would be probably untrue. Therefore, the typical precautions you take would be reasonable.
Okay.
Just add to that I think the general public's typical precautions are too loose. So I don't think our LAM patients should be hanging out like Joe Public out there, because I think Joe Public is doing a little too little. In other words, on an airplane, good God, you're sitting next to a stranger, and I think people are deciding to fly on airplanes today, even though they know they're sick. So you can't stay away from someone. So you should be wearing them if you're going to be on an airplane, and go if you have to. But if you're going to be on an airplane, you should be wearing a mask, and it should probably be a really good mask, like an N95 or a KN95. And you probably shouldn't be hanging out for a half hour sipping on your drink during that flight, because you should have the mask on the whole time, and while you're in the causeway and in the airport, and if you're in a crowded restaurant or if you're in a crowded place. I think whether you have LAM or you don't have LAM, you should be wearing a mask still. That's the way I behave myself. So I'm maybe a little stricter than the average person, but I guess I've been tainted by seeing too many bad things over the past 1.5 years, 2 years. So I think, so the point is, yes, I think standard precautions are good, but I think standard precautions ought to be different than what the reality is out on the streets.
Okay. Dr. Bakir, did you have anything to add to that?
No, I think I totally agree. I still wear masks when, like, we are required here at Mayo to wear masks, but when I go for grocery or anything, I still wear mask and maintain distance. I think it's important whether you have LAM or not. It's reassuring that LAM, when patients who got COVID, they didn't do worse than the general people. And there is some basic sciences data that mTOR inhibitor might have protective effect against the virus, but that doesn't mean that you should not take the precautions.
Right. Well, that kind of leads.
I guess I want to say a little more, because I don't want to send the wrong message.
Go ahead.
I don't think people need to live in bubbles either. And so to have a small gathering with some friends or family is important and good, and you can do that without a mask, especially if you know people aren't feeling sick and they're vaccinated, hopefully, and you can eat and drink and sort of be unmasked with a small group of people that you know and trust. Outside might be better than inside when possible, but that's not always possible either. So it's okay to open up your life some. I would just say that when you're, it's a risk reward decision. Like, there's a very small risk a yes. But if there's a big reward, like, you know, being able to enjoy your social life, that's good. If there's a very small risk, and what's the reward of having your mask off in a grocery store? It's minimal reward. So like the risk reward goes towards wearing a mask, in my opinion. So
That's good info.
Yeah, and to clarify, I wasn't claiming that we should not wear masks and not wash our hands and not socially distance, but I've had many patients ask me specifically, because I have ILD or I have LAM, should I just live a different life from others? And I don't think that you have to Dr. Ewing's point, live in a bubble or anything else, but I would certainly agree that myself, I still wear a mask in public, and to Dr. Ewing's point, people in airports, restaurants, everywhere act as if the pandemic had never happened, and they go about their business without that kind of regard. And there'll be people who are sick who will not care to test anymore, and it's not a matter of protecting you anymore. So indeed, those precautions are what standard someone should do, even if they don't have LAM or other disease.
Very good. And that kind of leads us into our next question, and it's about the International Lamposium this year. It's going to be in person, and they're requiring attendees to be vaccinated. Do you think this is enough of a precaution to make it safe for LAM patients to be in such a large group?
Shar, you want to take it?
I don't think she does.
No.
Connection just dropped.
Yes, no, I think I would, if I could please defer to our clinic directors, I think.
I think if you're masked and you're vaccinated, as I said before, we have seen that patient got COVID even when they were vaccinated. In our colleagues got it, many of them, there is a risk, but I think the risk is, if you're vaccinated and you are masked, the risk is relatively low. So as we discussed before, I think it will be okay, but not 100% protective.
yeah, think about my risk reward conversation. So there is a big reward to being able to learn and educate and be supported and network and all these things that happen there, and to do so with a group of people that are vaccinated and wearing a masks, and that will be the case, and are I think more aware of making sure that they're not going to enter the place if they're feeling sick, or test and, you know, get out of there if they are, or whatever. I think with all that said, I think it, and remember also what we've said about the data that exists around risk of severe COVID in LAM patients, and even LAM patients on Serolimus not being a high additive risk. I think on balance, the risk reward goes towards it's okay to be there, knowing that you're going to be careful, and so is everyone else.
Dr. Mua, anything to add?
I would to clarify, masks are required at the event.
Shar, I don't know, have they made a statement about masks?
Yeah, I'm right now, and this is under conversation every day, so please everyone know this. We're looking at it, and that final decision will probably not be made until right before the conference, but at present, and I'm reading from our website, that face masks are encouraged but optional. At this time, face masks will not be required at Lamposium. The foundation strongly encourages using face masks to limit the spread of COVID. However, we acknowledge that it is difficult for some patients with LAM to wear a mask for an extended time. We will continue to closely monitor. So what I'll do is put the link to our COVID-19 safety page for the conference in the chat box. And that is where I would recommend for those of you who have questions about this, or all of us really, to be paying attention. That will probably be updated at least a couple of more times prior to the conference.
Thank you.
You bet.
All right, and we did have a question come in here that kind of fits in nicely now about the COVID risks for LAM women over the age of 65.
They're the same for less than 65.
Okay.
I mean, the risk doesn't go up with the age. The question is that if you get COVID, would you do worse? And I think according to the studies, no.
Okay. Anyone else have anything you want to add to that? Okay. If we
It's a
test,
small incremental risk, and I don't think it should be a major factor in thinking about it.
all right. If we test positive for COVID, should we call our doctors about an antiviral drug or monoclonal antibodies right away, or wait to see how bad our symptoms get?
I think you can tell your doctor right away. It probably would be better. The other thing is that here in Minnesota or Mayo, they do this once you tell them that you're tested positive. Sometimes they do this virtual visit or make a telephone call and make sure, or sometimes they send you when it was severe COVID, they would send you a pulse oximeter and they will be remotely monitoring it. So there is an advantage of telling somebody, and they can, depending on your symptoms, they can keep an eye on you. So that would be helpful. But the treatment, the monoclonal antibody or these medicines that we talked about, they are for those patients who have symptoms. But if you have severe symptoms or requiring oxygen or requiring hospitalizations, then the only drug that will be given would be remdesivir. So, but outpatient treatment is only for patients who have symptoms, but those who are requiring oxygen, etc., they're not eligible for treatment. So you should have symptoms, but not very severe, and that's when you will get these antiviral medicines, and that they have to be within 5 to 7 days after the symptoms. The treatment, if you are eligible. So basically, I would say that if you are COVID positive, it's better to tell your physician, and they will decide whether you will get any treatment or not.
Okay. Anyone else have anything to add to that? Okay, so then the next question, Dr. Bakur, is are those antiviral drugs and monoclonal antibodies, are they readily available now, or is there still a risk that we might not be able to get them if we get COVID?
What I think is that they are available. The monoclonal antibody, the one which is now given for this Omicron BA.2 variant, is bebtelovimab. And it is, as I said, it is reserved only for those who have symptoms and who presented within 7 days of onset. If there is scarcity of this, if there is high demand and they cannot give this monoclonal antibody to everybody, they use this scoring system, which is called Monoclonal Antibody Scoring System, or MASS, and they take into account different factors, your age and kidney disease, immunocompromise, etc., and then or pregnancy. Then they decide whether one should. Then they, according to the scoring system, they decide whether they will give preference to one patient to another. The antiviral medicines are available, and there are 3 of them, which are remdesivir and Paxlovid, and the other one, molnupiravir. So these are, only remdesivir is the one which can be given inpatient, but the other 2 are outpatient treatment within 5 days of presentation, and your doctor will decide, but they are not in shortage these days, whatever I have read about them.
Okay, great. And then we had one more COVID question come in. It was, are LAM patients more at risk for long haul COVID?
I will pass it to my colleagues.
I don't think we have any information about that, and I don't think there's any special reason to think so.
Yeah, Dr. Dilling, I just saw your message that you need to drop here shortly. Thank you for joining. We really appreciate you chiming in and giving your input.
Thank you so much.
Thank you.
Okay, so next up is travel. And people must be interested in getting back out into the world, because there were a few people asking the same questions here. So for air travel, are there any concerns about multiple takeoffs and landings in one day? And should we only be taking nonstop flights?
So multiple takes off and landings probably doesn't have, I mean, it can increase your fatigue, but it probably doesn't have anything to do with increased risk of pneumothorax or anything. This is, I did talked to our altitude medicine doctor, and I also talked to another pilot, and they both said the same thing, that these frequent landing and takeoffs, they don't increase the risk of pneumothorax or any complications from LAM.
Okay. Dr. Moa, anything you want to add?
I think that's correct. There, I couldn't find anything specifically where someone looked at the number of flights or the frequency of ascent or descent as increasing that risk. And so I don't think we can say specifically, but in the absence of that, I don't know that that would be viable to say that that you should only take one flight across the country or something like that.
And then the next question is related. It's particular planes. Do any particular planes, smaller planes, or a specific type of plane cause any greater risk to us?
So all these planes, whether they are 737, Airbus 757, they are required to have a pressure or equal to 8,000 feet altitude. So they are all pressurized equally. It's not that the smaller plane have less pressure or more pressure. They're all, whether they're small or big or all have the same, that is a requirement that they should have at least this much pressure at that altitude. The only one exception is that 787, which is a newer one, that can have pressure, that you can go to high altitude with low pressure, which is up to 6,000 feet altitude. And if you are particularly asking for that aircraft, maybe the risk of pneumothorax is lesser compared to the older one. But as somebody asked about the domestic flights being safer or not safer, there is no difference in that. The problem with pneumothorax and LAM is that if you have a cavity, which is it's not communicating with your trachea or larger airways, and it is a cavity in itself, then it poses a risk of pneumothorax. So the aircraft difference doesn't make too much of a problem or of a difference here. That if there is a non-communicating cavity, it would be this. The risk probably would be there even if you take 737 Airbus or 757, maybe a little bit better with 787, but the risk will be there. There are certain studies that can be done before air travel to see if there is that cavity, but none of those imaging studies are optimal or the best one. So in short, there would be a risk whether you travel with one aircraft or not, but the risk is very, very small. We are talking about 1% or 2% per 100 flights. So the risk is, now if you take all the patients who had pneumothorax during air travel, or all the patients who had pneumothorax in LAM patients, the number one risk is air travel. But you can safely have like 100 flights and you might have one pneumothorax. So the risk is small.
Okay, someone just asked what you mean by cavity.
It's not the cavity, like a cyst.
Oh, a cyst, yes, okay.
Yeah.
Okay, and then the final travel question is, what is the best climate for LAM lungs? Cold weather, hot weather, dry, humid?
I am not 100% sure about that answer. I think that any obstructive lung disease, whether this is asthma, whether this is COPD, whether this is LAM, people have different triggers, and they always say that most of the patients say that they feel worse with humid weather. Some people say cold weather is not good for them. Some people say any change of weather is not good for them. So I feel like that it is an individual thing. It's not that I can say for everybody that humidity is bad or cold weather is bad. But I would like to hear from Teng. What does he have to say?
I agree. I think you have to define what you mean by better or not worse. Meaning, if you live in Arizona, does your FEV1 decline faster than if you lived in the Northeast? And I don't know that there's any science to say that specifically. So I think to Dr. Bakir's point, it's a matter of comfort and triggers. And for some people, they like the cold air and it feels better in their lungs. And so they breathe better during that time during the very hot, humid summers. For some people, the cold air triggers bronchospasms or makes it hard to take a deep breath, and they like the warmer air. But to say that there's a measured study taking LAM patients and saying that different regions of the country have better survival because of the weather, or their FEV1 decline is different because of that, I'm not sure we can say that scientifically.
Okay. All right. Next category is exercise. Should all LAM patients go through testing before starting an exercise program, or can we just track our oxygen levels with and pulse with an oximeter at home?
I would say that it all depends on, for example, if you are a very active person, have minimal disease, and you are running anyways and doing regular exercise, I do not think that you need an okay from the physician to undergo any exercise program. On the other hand, if you are somewhat older, like greater than 65, 70, you have FEV1 is like not that great, like -30, you have increased burden of cyst in the lungs. I think it is better, and you haven't exercised before, you are on supplemental oxygen, then I think it is better to have your pulmonary function test and 6-minute walk test, or maybe cardiopulmonary exercise test done before you start any program, just to avoid any problems or desaturation or complications during exercise.
Okay. Dr. Moa, did you have anything to add to that?
No, I don't think so. I think the CPEX, or the cardiopulmonary exercise test, is usually looking for, in our experience, to find severity of disease or to define why someone is short of breath. In this setting, you probably can attribute most of your shortness of breath to LAM. And so that's a diagnostic test that tries to tell you if you have an additional heart issue or something else. Oftentimes, if you are, what Dr. Bakir said, more advanced, you already are very limited, you're on a certain amount of oxygen, but you want a condition. If you don't want additional testing, sometimes it's going to a rehab center to get pulmonary rehab. Just formally getting PR is going to be a safe way to start, because they will formally exercise you and they'll monitor you and make sure you're safe. And then you can have a prescription or have some sort of guidance as to what is tolerated well and what's not, in a formal way without actual testing in the sense. But basic lung function testing would be reasonable to know how severe your disease is. Oxygen titration, to know how far you can walk or how much oxygen support you need, would be basic things to start out with if you already are on oxygen or if you already have a certain level of deconditioning. But if you have that in place and you say, let me get started, and just being referred to a rehab program might be a way to start, and you can carry that on way long after the programs are done.
Great. And have you guys found that there's a best exercise for LAM patients, particularly if they aren't into running or?
So I think Teng knows way more in rehab as I do, but what I have found is that there is only one study in LAM which was published, and I think I talked about it some years back before COVID in our LAM meeting. In 2016, it was published in European Respiratory Journal, in which they compared patient with LAM and I think with COPD. And the exercise regimen in that study was 1 hour of half-hour of aerobic exercise like walking, treadmill, etc., and half-hour of strength training or resistant training. And they did, I think, once or twice a week for 24 weeks. And there was significant improvement in their endurance time as well as quality of life. So based on that, I would recommend that a combination of aerobic and strength training is what I will recommend. But there was one study which was published in 2020 in which even doing yoga was helpful in improving the 6-minute walk distance in LAM patients. So I think any kind of study, any kind of exercise would be helpful. But as Dr. Teng Moa said, that if you do a formal rehabilitation under somebody's supervision who is monitoring your heart rate and your oxygen saturation, etc. That would be the safest way to start to go. But some of the patients have mild disease, they're physically active, so they're just looking for an exercise program and they have a pulse oximeter at home. So you can have a combination of aerobic and strength training. But I would definitely ask Dr. Moa's input in exercise questions.
No, I thought that question was very funny because it said about the 10 miles, and I
Yeah.
thought that was very funny.
I love that part
I
out.
love that part too. I know it's interesting
Particularly
because
if you aren't into running 10 miles a day was the specific question. Yeah.
and I'm not making light of it. I think most people who are healthy don't want to run 10 miles. And
Exactly.
so what I mean by that is, and when you have a so-called normal lung with lung function, people already have a hard time exercising in life. So when you have a lung disease, there's a little bit of a disadvantage you have to go over with. But I've worked with our mindful breathing lab program here with Dr. Benzo, who is a big advocate of exercise in chronic lung disease. And I think the mantra in mind is not so much exercise in the sense of exercise, sweats, getting on some sort of formal time regimen. I think the lessons I've learned from him that I might carry on to you would be just physical activity. And we've done studies where, as measured by steps per day, people with chronic lung disease, low FEV1, can still improve a portion of physical activity. And that's measured by actigraph, measured by all these scientific measurements. But if you translate it to steps per day, people get up and they move around, and where they haven't done so before. And perhaps the exercise that you do for 20 minutes, 15 minutes, whatever choice you pick, should translate to that more than the fact that you do exercise and then you just don't do anything else the rest of the day. I think if it offers you a chance to be freer and do other things like that, that'd be helpful. Lastly, I think walking is underrated, but I think walking is very important. And I think that's made a big difference. And especially if you're not someone who runs 10 miles a day or even gets in an exercise program, I've told my parents aren't quite elderly yet, but just simply walking 20 minutes a day, 15 to 20 minutes a day as recommended by many cardiology groups improves outcomes, improves people living longer in the setting of good health. So if you take everybody who's got good health and those who walk and don't walk, the simple act of walking 20 minutes a day improves longevity, reduces risk factors for certain heart and lung disease, even cancer risk. And so I think that may translate even to LAM, that if you are not someone who's going to be power biking on Peloton, if you just walked around your living room, walked around your neighborhood for 20 minutes a day at the pace you wish to take, that might be simple enough. It's to some degree core strength building, it's walking, it's balance, it's all these things that are combined together along with a little cardio. And so it doesn't require much thinking. We've been walking for a long time in our whole lives. And so even that learning aspect of it isn't hard. And so at a minimum, I think that might be relevant doing, but anything else you can do physically, feel free to partake. And I would put in your mind, it's a lifestyle thing. It's a physical change in what you do in terms of activity. Not so much if I put in my 30 minutes, that's all I need to do.
Yeah, the American College of Sports Medicine, this is not regarding LAM. The American College of Sports Medicine, they recommend that you should do any activity at least 3 to 5 days a week, which is moderate, like you can carry out your conversation while you are doing that, and for at least 20 minutes a day, and involving large muscle group, like for example, walking or like your legs. And that is a recommendation from American College of Sports Medicine. But any activity, as Tang said, any activity would be helpful.
Great. And there was a question about whether or not LAM patients need to limit how much weight they lift if they're doing weight training.
I cannot say that there's a study or some sort of ratio of that. I guess my main concern, and Dr. Bakir may know more than me, and even you as patients may know more than me, is just the Valsalva risk when we weight lift and whether that increases risk of pneumothorax. I think sometimes I've heard patients who are younger athletes who are at the gym lifting weights, and that might be their first occurrence in pneumothorax, but I don't even think that's more anecdotal than anything else. I don't think one can say that, because you can't measure Valsalva. You can't measure, you got a bigger Valsalva than I do, so you had a higher chance of risk of popping your lungs or not popping your lungs. That's the only precaution I might take with that, but you can be taught to breathe through those exertional exercises like that, where you don't hold your breath. Let's say you're pushing dumbbells over your head and you're holding your breath in Valsalva, just grunting or holding your breath during that time. You can probably be taught to breathe through that, and I think that in and of itself should not put you at risk. So the short answer would be do it safely, and it would be that no, you should not limit weight training. Weight training is also helpful for muscle mass gain. It's got its own health benefits, and so LAM specifically should not take you away from that.
What and I might be wrong in that, but what I understood from the study that I mentioned in 2016, where they did this weightlifting. So for example, you are able to lift, like you're doing bicep, and you are only able to lift, like maximum weight is 15 or 20 pounds that you can lift. So in that particular study, they went down to 50% of that. Like for example, if your maximum weight is 30 pounds, they went down to 15 pounds, and they asked the people to have 8 repetitions of like 15 pounds. So that would be one way of a rough estimate how you should start. And then you can go from 8 repetitions to 12 repetitions of weightlifting, so that you can prevent what Teng was referring to, that Valsalva maneuver and possible pneumothorax, that you can go up on your repetition rather than going up on the weight and grunting and that. Any resistant training would be helpful, as mentioned, that even yoga has a lot of resistant training moves, and that can also help with strength training and toning your muscles.
And my only thought, and not because I'm an expert, is the large compound movements are probably more relevant for all of us, not just no matter our age. What I mean by that is large muscle groups. So you maybe squats, chest presses, lifts, where you have 2 joints that are moving at once. And so oftentimes that's recommended by most trainers as having the most efficacy for the effort. And so these specialized moves that the bodybuilders do, where you're working on more muscle group, probably aren't as relevant as these larger body movements. And they include things like deadlifts or chest presses or overhead lifts. Just standing up from a seated position, like a squat, for example, oftentimes those are more relevant than to do these machine-based focused targeted areas. And I guess I'd ask Dr. Bakir, that study there, I remember that study, but I don't remember if they listed pneumothorax risk factors or anything like that.
No, I don't think so. There was
as a complication, right?
There was no pneumothorax in that study.
Yeah, because that's, I mean, that's probably one of the few studies that formally watch people exercise with LAM over time. And people are going to do what they do. And so if they didn't know that, they were going to create a situation where they had pneumothorax, we would capture that or see that. And if it wasn't increased anymore, then what other people would do, I suspect that risk is probably anecdotal or minimal.
Yeah, and the best thing or result of that study was not only the endurance time, which is obviously is a big thing, but the mood and the quality of life improved in after 24 weeks. So I think that was a very important take from that, because many of time we are dealing with stress, with chronic conditions, and we are dealing with mood issues, and as anybody would imagine, but that study formally assessed that, and that helped with answering those questions. So I think exercise, definitely whatever you can do would be helpful.
Great. There was a question that came in about oxygen levels when exercising, and if it's okay to drop below 90 for a few minutes.
Yeah, 88 is usually considered kind of cutoff point. If you are staying below 88, you should be on supplemental oxygen. So I don't know how low below 90 that the oxygen goes. Okay.
And then there was a question to Dr. Bakir about getting a citation for the paper that you referenced.
Yeah, I will. I have written down in my notebook page, because I discussed this like in previous meetings. I will get the reference. I also want to ask about, maybe Shar would know, there was a lady in LAM Foundation, Dr. Brown, from Seattle, who was also recruiting patients for rehab and whatever. Do you know of anything?
Yes, yeah, that great point, Dr. Bakir. So that study has wrapped up, and Dr. Brown presented for us in, oh my gosh, I have to look back at I'll put the Lamposium in your living room link on the or into the chat, because she did a two-part series for us, if you will, as part of our Lamposium in Your Living Room webinars. So she presented when that study was first enrolling, and we were looking for participants, and then she did a second follow-up for us, and she will be presenting as well at Lamposium. So to follow up on that, but she did a great job with that presentation. So
Yeah, I've heard her talks. Yeah.
yeah.
great.
And I think, well, I know we're short on time, so that if we move to group discussion, Sharon, I know we have a couple of participants on the call, so.
Okay, yeah, and we are moving into random topics. Now, before we do, Shar, I just want to make sure you captured Elizabeth's questions in the chat about that. We probably want Dr. Dilling to take a look at.
Okay, yep, I'll get that.
You got that?
Yes, and I can, and I think Doctors Bakir and Moa could address this as well, but yes, we do have had patients with TSC lamb receive transplants. And the rest of, yeah, but we can follow up. Elizabeth, I would love to contact with you. I don't want to, if we have time, Sharon, to move into that, but yeah, I think we can discuss those questions, definitely.
Okay, thank you.
You bet.
All right, moving on to our random topics. The first one is, can stress cause lamb to progress more quickly?
I would say that I'm not 100% sure about lamb per se, but any chronic illness, whether it is COPD or pulmonary fibrosis or anything, stress has a lot of negative effect on any chronic condition. And there are some, I'm pretty sure there are many physiologic reasons, and one of them is just this fight and flight situation. Like whenever you are anxious, there are a lot of harmful chemicals that are secreted, and they can have negative impact on general health of any individual. So stress is not good for anybody, and I'm pretty sure that it has worse effect on people with any chronic condition. So I would say, I don't know whether I can say directly that stress would directly affect lamb, but I think in general, just any chronic condition, stress is not good.
Mm-hmm.
Tang, do you want to add?
Yeah, Dr. Moa, anything?
Oh yeah, I think chronic conditions and diseases create stress for you, and so it's not a matter of you saying that I can have control over a lot of these things. I think we just, and it's easy for people to tell you have to kind of re-engage yourself or find a different framework and so on, and everybody responds to that differently. But to recognize that there's secondary impacts, and stress is one of these, from having disease in the first place. And now whether that circles back around to creating a situation, I think that can, from the perspective of how you manage things. I'll give you examples of patients who are too stressed to take their medicines, and so that might lead to increased acceleration of their disease or intolerance to certain things. Maybe the stress creates situations where in chronic diseases, you need support from your loved ones and your family members, and that actually improves your health, where they might take you, remind you of your care and participate in your care. And if those are stressful situations, that those are tensions that are there. But I don't, there are probably going to be some data that says that however you measure stress, the less stressful people are, objectively, they seem to live longer or have better FEV1s or things like that. That might be true from the behavioral aspect. I don't know if there's a mechanism by which the cortisol level leads to a certain loss of effect from the Serolimus or something like that. That's what I mean by I don't know from that perspective. Yeah.
Okay, and the next question is about pregnancy. I remember hearing about one lamb patient in our region that stayed on rapamycin during her pregnancy. Have there been any others that we know of?
Yeah, that is my patient, and she did very well with pregnancy while on Serolimus. So I did contact Dr. Gupta about that case that he told me about 2 or 3 more cases who were on Serolimus and had excellent pregnancy result, no problem with fetus. So yeah, we have a handful of cases which remain on Serolimus through pregnancy and did okay.
Okay. And then the next one's, are there any effective non-hormonal ways for lamb patients to combat side effects of menopause, such as hot flashes, night sweats, and weight gain?
So for menopause, their usual recommendations are that you start with lifestyle modification, which, and the good news is that menopause symptoms eventually they do go away. So those who, at 1/3 patients will experience this. Not all the patients with menopause would have hot flashes and everything. So, and they, over the years, they will go away. So basically, if you are dealing with hot flashes, then the wearing layers so that you can take off and put it on, etc., would be helpful. Maintain a healthy weight is helpful, and lowering the temperature of your surroundings, like in your house, etc. Avoiding caffeine or alcohol is recommended. Smoking and decreased stress. That these are all the lifestyle modification against hot flashes or menopause, postmenopausal symptoms. There are, the second category is mind body, like acupuncture, massage, tai chi, etc. These are also recommended. Relaxation techniques, whatever you can do, yoga, etc. The non-prescription supplements, there are many over-the-counter supplements, soy or black cohosh or vitamin E or red clover or kava kava or ginkgo. There are many, but the problem with those are that they're not regulated, and they you can have impurities in them. So therefore, no physician would ever tell you to use those. Dr. Larkin from Lamb Foundation gives excellent talks on these topics, and she says that they probably would be okay to use, but she also says that okay is not a good term to say. So like, I mean, we don't know that basically, but she did talk about this over-the-counter product called Relizen, RELIZEN. And she thinks that there is one study done which proves the efficacy of this product, which acts like antidepressant, but it's not antidepressant per se. It's not a medicine. So she says that if anything, I will use this product for menopause. Amongst the medication, non-hormonal medication, she recommends or she talks about oxybutynin, which is again a medicine, but it is not hormonal. So oxybutynin was given to patients with prostate cancer who were on Lupron, and they were dealing with the menopausal symptoms, and it helped them. So based on that, oxybutynin is also used for hot flashes. It can cause dryness in the mouth, but it is effective. If you're dealing with sleep issues, whether they're related to menopause or not, Neurontin or gabapentin is another one that can be used. She did talk about Effexor, which is an antidepressant for it has been used for hot flashes, but any antidepressant would have negative effect on sexual health. Like it will make the vaginal atrophy or dryness worse. So therefore, antidepressants is usually be avoided for postmenopausal symptoms.
Okay. Dr. Mo, did you have anything you wanted to add?
No, I think Dr. Bakir covered that very well.
Okay. We did have a question come in after I sent you guys the list about the best treatment options for ascites, is it? Ascites?
Yeah, so chylous ascites. The studies have shown that Serolimus or Everolimus both have good effect for treating chylous ascites or chylous pleural effusions.
Okay. And then the same patient had a question about, she doesn't have a specialist in her area. So how does she work with a doctor that's never treated lamb? Do you have any suggestions?
Well, I think can he or she travel to any center close by?
Yeah, I'm not sure. That might be a suggestion. Yeah. Otherwise, is there any options for them to reach out, like a general physician to reach out to specialists and
Yeah, I think it depends on how busy the doctors are in specialized areas. They can do like, they can do consultation. They can tell you what to look for. They can, one way is to be enrolled in LAM Foundation and go all the testing at NIH, which is free of cost, and you will have a better assessment of your health, at least at baseline, which is free of cost. Your whole travel is it this? It is true, Shar? Is it still going on?
It's my understanding, yes, the protocol is open, but it's my understanding at present, and I will double check on this, that first-time patients do pay their travel. That was a travel grant originally. Follow-up visits are fully funded by the NIH.
And I can't remember if this patient was in Canada. Do they? Oh, she just responded. It's only for US citizens. Okay. So for Canadians, that wouldn't be an option.
Right. Yeah. Is this in the chat box, and this patient can contact the foundation and might be able to get her in contact as well. So we'll reach out to either Erin or me. Yeah.
Okay. And then we have a question about how often should you see a LAM doctor if you've been pretty stable for years and not on oxygen or Serolimus, and an FEV of 56?
56, and you're not on Serolimus?
Not on oxygen or Serolimus.
Okay.
This is Jill.
Oh, Jill, that is, so if it is stable and it's not going down, I would, and if it also depends on the menopausal status. So if you are postmenopausal and it has been stable, you can see once a year. If you are premenopausal, you can, I would say, this is not hard and fast rule. I would say that maybe every 6 months, or it can be a year too, but maybe more frequently if you are premenopausal.
Okay. Oh, let's see. Tamika, I'm from Toronto. I've gone 3 times prior to the pandemic. Highly recommend. Oh, to NIH. And so Canadians can go to NIH then. All right.
Yeah, I want to make sure that was, I think that got kind of tangled. Yes, international patients can attend.
Okay.
Sharon, can I interject for just a moment?
Yep.
I'm in Canada. They used to pay for Canadians to get there. They don't any longer.
Okay.
Your flight needs to originate in the US, and then they will pay for you to go to NIH free of charge. I think the first visit is still at your own expense. So if you're Canadian that lives close enough to the border that you can cross the border, then it's free. If you're in Northern Canada and you can't get to the border, then yes, you will incur some cost to get there.
Oh, good input. Thank you, Hallie.
Welcome.
All right. We are almost at time here. I did want to allow some time for us to talk about the Circle of Hope. Shar, did you want to give an overview?
Sure, thanks, Sharon. First of all, I just want to say fantastic questions, as always with this group, and Drs. Bakir and Moa, thank you so much for the preparation and everything that you've done to make this happen for this group again this year. The Circle of Hope program the full name is the Circle of Hope Transplant Support Program, and it is pretty much exactly what it sounds. It's basically peer-to-peer mentoring and education and socializing. So at the heart of this program, we have Dr. Dilling as a resource, right, which is fantastic. And then at the heart of the program, what we do is we match women who have undergone the full transplant process. They're typically at least 1 year out. We aim for 2 years post-transplant before we put them in a mentor role. And we match them with women who are either considering evaluation or perhaps already listed anywhere in the transplant process. We've even had a couple of people join the program once they've had their transplant. They just weren't aware of us prior. So we kind of match you up 1-to-1, or sometimes you'll be talking with 3 or 4 people. It's just a connection mechanism, if you will, to help you be able to talk with people who have LAM and now also have navigated the lung transplant process. As Dr. Bakir stated earlier, there just aren't that many of us. So this opportunity to connect and come together is invaluable. And so we have social gatherings. I know we have a couple of people on here today who have been on those, where the women, we just simply gather ourselves. We usually wrangle Dan or Dr. Dilling in for a few minutes to field a few questions. And then we just have an opportunity to share and ask questions. And then we have, usually as part of our Lamposium in Your Living Room series, at least one transplant related webinar each year as well. So, and then we also talk a lot about tissue donation and the value of contributing to research and just the meaning behind that. And I will shamelessly add a plug, because it's that fresh lung tissue from our transplants. You know, while our lungs are no longer serving us all that well at the time that we're headed to transplant, they are absolutely, it is gold-plated tissue for our investigators. And it's a really amazing feeling to be able to contribute that. So that's it in a nutshell. I'm happy to answer any questions if anyone has some. If you scroll back in the chat, you'll find my information for contact, or you can find it on the website as well.
Thank you, Shar. All right, well, we are at time, and I again want to say thank you to the doctors for preparation and spending their time with us today, and to all of you for joining, all the wonderful questions that came in advance and during the meeting. It was great to have patients from all over Canada and Illinois, as well as our regular region as well. You know, in the future here, I hope we get back to in-person meetings. Those are wonderful, but we did talk about, once we go back to in-person, if there's a way that we can either record them or stream them so that more people can join as well. So we will try to continue to keep this larger audience involved going forward.
I would say that I'm very thankful to all the LAM Foundation and to all the participants. Your questions were excellent. It gives us the opportunity to learn as well. Believe me, those questions, they come from some very intelligent minds, and we have to dig our data and everything to look for the answer. So thank you so much for these great questions.
I concur entirely. Thank you for being here with us.
Thanks. Thanks to all. All right. Shar, any parting words of wisdom before we go? No?
There we go. Yeah, no, I was muted. No, I mean, just again, huge gratitude to Dr. Bakir and Dr. Moa and Sharon and the Canadian liaisons here in Nikita. This is fabulous. I look forward to this meeting every year, and just thank you all. And if you have any questions, reach out to Sharon and let her know.
Yes,
and or contact the foundation. We will follow up with the recording of this video. It does take about a week for us to get it through our communications person and upload it to the website. And any follow-up questions, I made notes, so we'll reach out to those people individually. So
are people coming for September meeting?
We have, you know, I don't know the exact head count right now, but I think, hold on a minute, I can pull that report really quick. You guys bear with me for 2 clicks here.
Are you coming, Dr. Bakir?
Yes, I will be.
You are. Okay. I haven't registered yet, but I'm planning to go.
Yeah, let me do. At present, we have. I'm looking up number of attendees, Sharon. So at present, we have 218 people registered, and that does include our speakers, investigators. So I'm not certain the breakdown of patients, family,
yeah.
or speakers. So.
Because it is in Chicago, so it's close to our region.
Yes.
Yeah. All right.
Okay.
Well, thank you again, everyone.
Thank you, everybody.
Once we have the recording, I'll make sure that gets out to all of you.
Yep. Okay.
All right. Thanks.
Thank you.
Thank you.
Thank you, everyone.
Bye-bye.
Bye-bye.